Right.
All right. Well, welcome to our second attempt to record this episode. This is not an easy one.
This is complicated.
And you'll see why. So in this episode, we wanted to conclude season 1 by talking about the socio-economic elephant in the room. A massive elephant. We've talked about elephants and elements before in previous episodes of this podcast, but this is I think the one that I feel at least is pretty much the most important one to have.
Well, it contextualizes the whole thing.
Yeah,
of what we've been talking
it does. I mean, if we don't have an understanding or at least an acknowledgement of these problems, then any sort of advice that we give out when it comes to nutrition is going to be, problematic. Really,
or even any dialogue that we try to have around, kind of what needs to be done, and everyone's obviously got opinions in that respect, is having a conversation just at the wrong level about the wrong issues that ultimately don't matter. Like, we can argue till the cows come home about, how much carbohydrates someone eats, or, whether we need to eat more fat or less fat and all this stuff, but it just doesn't make a difference. Because at the end of the day, we have a diet pattern in the, quote, Western industrialized world that is fairly homogenous, that is the same across in terms of its macronutrient composition in the UK as it is in Australia, as it is in the States, as it is in Ireland. So why is that? What's the output factor? What's the food supply issues that influence this? And then what are the social, economic, and obviously environmental determinants that make this diet pattern not only so ubiquitous, but so difficult to shift and address?
Yeah, because we talked in the last episode about the fact that actually within nutritional science, we do know quite a fair amount of stuff in terms of what constitutes, in quotes, a healthy diet. We understand what ideally we should be eating on a broad sense to kind of improve our overall health, to kind of reduce our risk of certain things. But the question is can we just therefore just tell people that I mean, why is that not working? Why can we, if we know this as a fact, like if we know that it is if we know that the majority, let's say, of our unsaturated fats should come from plant sources, why is that not happening?
Right.
Is this, is it what you commonly see online and commonly see within the discussions, just a matter of a lack of education? Or is it a lack of
personal responsibility and priorities?
Is it a lack of prioritizing? Is it, when all of this, and we'll talk about that, kind of when we start making this a personal responsibility on the individual, which within your own subset of socioeconomic class you could have an element of, but in general, if that's the way we're framing all of these conversations, where it's just, it's okay because I'll just tell you how to improve your diet and then you'll do it and it'll be fine.
Right.
But we're ignoring all of the barriers that there are in place, that get put in place through no fault of somebody, no fault of their own, but are just there. And if we're ignoring all of those,
if it was a matter of personal responsibility, then we are saying that the 17-year difference in disability-free life expectancy in the UK, so 17 years is the difference between people living without a major illness between the most socially deprived areas and the most socially advantaged areas, then we're saying that those people, that difference boils down to personal responsibility.
It's just
that they
fault.
live 17 years less because it's their fault.
Yeah.
And I think that morally, ethically, and in every other sense of how we could assess this, that's a fairly bankrupt argument to make.
Yeah.
And we can look at that disparity within a society. We can look at it between societies. These issues are bigger than nutrition. We can get lost in focusing on nutrition. Nutrition is one element of these wider factors. We're not going to disentangle all of them today. We couldn't if we tried. We want to try to keep the focus on nutritional aspects of this conversation. But in doing so, it's impossible not to touch on some of these political factors and the wealth disparity thing.
Well, speaking of the wealth disparity, it's quite for people who are at least starting to talk about this kind of stuff.
Right.
It's quite common to see a conversation take place purely about money, and it's all well and good to think that if we just increase the wealth, then it will increase health, and to some extent it does.
Yeah.
There is evidence to show that increasing the wealth of a country overall increases everyone's health. But that only works up to a point, and then it starts to level off. And after that, you've then got the societies and the countries that reduce the inequality the most that continue to improve health. And there's some, we were talking before this, or maybe in the last recording, about the fact that our life expectancy here, what was
on average. So when you improve, if a country is a kind of low middle income country, if you improve the overall wealth of that country, you'll see population-wide improvements in health outcomes as well. But the factors that seem to underpin that are things like increased sanitation, security in the food supply, decreased rates of infant mortality, which then brings the overall life expectancy of the population up, improved built environment, electricity, and these kind of variables. They're obviously not necessarily issues in developed countries or high income countries. So what you tend to see then after that initial improvement of those variables is that leveling off. And then you see that countries that increase the disparity in health and wealth, and it's not just, when we say wealth, it's not just monetary wealth, we're talking about different variables. But the greater the wealth disparity then can actually have a negative effect on on health, because you're looking at chronic lifestyle diseases. So in the UK, if we look at Chelsea Kensington, average life expectancy of a man is 88 years of age. Down the road in Tottenham Green, you've got average life expectancy of 71 years. You've got this massive discrepancy within a short time place.
Yeah.
So the other interesting, and I've posted this before from the Marmot report, is for every tube stop from Westminster to Canning Town, life expectancy decreases by 1 year per tube stop.
Yeah.
So
if we ignore all of these,
and
we're talking about nutrition like it's the be all and the end all of this stuff, we're being willfully ignorant about this stuff. Willfully, there you go. Whatever word. Take 6 million of this podcast. I'll get the word right.
But the point you said about it's not just monetary wealth is really important, because if we look at then average life expectancy in the UK is 67. That average life expectancy is the same as Thailand and Egypt, who are countries, and it's lower than the life expectancy in China, Belize, and Ecuador, which I don't think many people in the UK would think. And all of those are countries that have lower gross domestic product than the UK. And also they're countries that don't have a nationalized healthcare system. And so when you look at it through that lens, a much more complicated picture emerges. The UK is a wealthier country than these countries. Maybe not China anymore necessarily overall, but the overall in the population, the overall GDP per capita will be. And the UK has a national healthcare system.
And our life expectancy is no better.
And also the rates of chronic lifestyle disease are significantly higher. So this is a complicated issue.
And we don't have the answer to that. There are lots of elements at play there, and we're not going to try and guess the answers to that. But it's stuff that is worth being aware of. That this isn't just as simple as, if I just post on Instagram that everyone should eat more fruit and veg, I'll save the world. It's not as simple as that.
That's the arrogance element, I think, of for healthcare professionals, for people in professions that have a role in this broad space, policy, medical care. So we're talking about law, medicine, and these kind of professions. They're privileged professions. People tend to come from a certain socio-demographic background. They've probably gone to a private school. They've certainly gone to tertiary education. And so we have these conversations that kind of focus on these almost like missing the point issues.
Yeah.
And I've often said, kind of as my thinking's evolved on these issues, if you look at, say, a lot of the conversations in medicine now, it's very much this like, how can we, and it's not that we shouldn't improve health advice for individuals, but everyone focusing on that, like, oh, we'll reverse these trends through educating, doctors in nutrition, for example, and then they'll pass on the message in their clinic. No, like that's not, it still should be done, but actually medicine, law, and other powerful professions with political connections would be better off actually directing their muscle upstream for policy change.
I mean, that's us sharing an opinion, but it's an opinion I agree with you on. And I mean, even objectively, what we're doing so far isn't working.
No.
It's not changing the inequality. It's not changing the life expectancy disparity. I mean, even when something I was thinking of when you were talking about the fact that money isn't the only issue. The fact that there's a north-south divide in the UK, which not a lot of people necessarily know about. The fact that your life expectancy is lower if the further you live up north in the UK.
Right.
Even if you earn
even
the same
within
amount.
the same socioeconomic status.
So there's somebody up north earning £40,000 a year versus someone in London earning £40,000 a year.
Right.
The person's life expectancy up north will be lower.
Right.
And it's not just money here either.
No.
There are so many different barriers to nutrition, rather than
health.
To health in general. That aren't purely down to money.
And when it comes to nutrition and kind of public health, when it comes to public health generally, there's generally two approaches. We can talk about downstream interventions, which focus on the individual level behavior change. And we can focus on upstream interventions where we're focusing on policy, regulation, and those kind of industry level interventions.
Yeah.
And I'm not suggesting that we scrap downstream interventions, but unless we're modifying the environment in people's favor through upstream interventions, expecting personal responsibility with no environmental modification is a bit of a joke in terms of what we know.
Yeah.
So people are not like, the idea that we're helpless is not the case. Because again, not everyone in any circumstance, people that have the most advantaged in life may still get diabetes, and people that have, are born into areas of complete social deprivation may not. And so it's not just this linear split along socioeconomic lines. The point is, though, that the health and wealth inequalities make it increasingly more difficult for people to actually engage and access behaviors that might reduce chronic disease risk.
Yeah.
So if we're not modifying the environment by upstream interventions, the downstream interventions will largely be ineffectual.
Well, that's exactly what we see when it comes to what's known as the inequality paradox, right?
Right.
So providing the opportunity to access these things, so to access more fruit and veg, for example, providing the opportunity to people to access that is all well and good. It's not. I'm not saying it's instinctively a bad thing, but that intervention ends up being taken up by the middle classes in the end.
Right.
And so you can provide access to an intervention, but in the end, it actually ends up widening the inequality. The only
because people that already have the means and accessibility and time to avail of that and it's you're correct. There was a paper in 2007 by an American researcher at Tulane University who has published widely on these kind of determinants, and it was quite interesting because you'll get a lot of suggestions that, we could subsidize fruits and vegetables in low income areas. But the problem is, it doesn't matter if they're made available. There are other barriers.
Yeah, so let's take that further. So let's go. So let's stick on fruit and veg, and let's kind of address or bring up again. We don't have the solutions to these, but we need to have the knowledge of them. Let's bring up some of the barriers to fruit and veg consumption. So, I mean, number one is the actual physical availability to buy cheap fruit and veg. So,
which is non-existent in certain areas, particularly in urban, low-income, low socioeconomic status areas, which are now classified in many respects, quote unquote, as a food desert.
Yeah, and some people like to deny that that's a thing. I don't really understand why, but
it's not that it's denied, but some of the kind of more privileged narratives I've seen is that, you know, even if someone doesn't have public transport and lives in a food desert, they can still get the bus, you know, to a market and buy this, and it's just
go to a farmer's market. Yeah. So food deserts is a real thing.
Is a thing.
Supermarkets are businesses in the end, and so supermarkets aren't going to be built within deprived areas of the country because that's not a smart business decision.
And one of the things that we do know on that, and people can look at Public Health England documents, and there was one that models the density of fast food outlets in areas relative to social deprivation. And there was a linear association between the density of fast food outlets and the level of social deprivation. In some cases, we were talking about up to 199 outlets per 100,000 heads of the population.
Wow.
So we're talking about an incredible density of food. And when I talk about a homogenous Western diet in its characteristics of fat, carbohydrate, refined sugar, refined starch, low fiber, high sodium, and all of these variables, this is how that's possible at a population level. Because although there is an appearance of option between your KFC and your McDonald's, actually, kind of when you add that all up, really at a kind of macro level, they're quite similar in terms of their composition.
And we're not saying that fast food restaurants are the cause of this problem, but they're factors, and they are.
Well, they're symptoms of this. Can only where we're at with this can only happen because of the kind of economic doctrine of neoliberalism, or in the UK it's known as conservative libertarianism. And so it's this economic doctrine of the free market deciding, and within that we have transnational food and beverage corporations that are capable of penetrating a market, completely, drastically reducing the price of food, increasing the availability of that food, creating and engineering that food in such a way that it is of a certain palatability. And that is, and I say this pejoratively, a triumph, and I use the word triumph pejoratively, of the neoliberal economic doctrine, that we now have massive energy availability for very little cost. And that is placed strategically in areas of the most social deprivation, because you're talking about in a relative purchasing parity, people that by nature, in terms of once other variables like rent and stuff are available, there is often, and this is a barrier, one of the barriers we're talking about, limited available resources for food purchasing in the household. So the household food purchasing power is actually quite low. So by default, a KFC bucket meal deal for £4.99 becomes not just appealing in terms of the volume of food, but actually a necessity. And this idea that there is a personal choice in this equation to opt for that, or go and do a big vegetable and fruit shop, is just to absolutely ignore all of these economic determinants.
So that's a common thing that I see as well, is you'll have an Instagram post of a comparison between the price of a KFC bucket,
Right.
and the price of making the meals from scratch, and there'll be a justification that actually this is cheaper to make the meals by scratch. So you're
If you're
just
Jamie Oliver,
you're just choosing the wrong thing. Then that goes
we're
back
to food preparation skills.
then we go back to when we were talking about the different barriers to eating more fruit and veg. So we talked about access itself, so food deserts themselves. There's often a massive emphasis on education. And my personal opinion is I think that becomes very moralistic when you talk about that. Education is an element. It is a factor.
Right.
There is going to be an element of the knowledge of how to cook certain foods, the knowledge of how to make certain things.
The knowledge of cooking is food preparation skills. But the knowledge of what is or isn't good for someone in the broadest sense. And one thing that's often lacking in nutrition research that we could maybe take if we look at nutrition more as a social science, which in many respects it's becoming, is the human voice, is qualitative research. And I remember when the Eat Lancet report came out, I took quotes from some qualitative research that I thought were quite powerful to show why it was such a classist pile of nonsense in the first place.
Well, just to clarify, because I know what that is, but some people won't know exactly the Eat Lancet.
Okay, so the Eat Lancet was a foundation called Eat that developed a diet.
Planetary diet, was it
they
not?
called it the Planetary Health Diet. That was a largely plant-based, you could have 7 grams of meat a day, 49 grams a week, and an egg, and maybe 200 grams of dairy. And so, but
you had to shop at farmers markets. Was one of the
recommendations was people can do this if they shop at farmers market, and here are all these delicious meals you can make at the home. So it was an entirely classist document that had very moralistic overtones of not only can you save the planet, but you can also save yourself if you eat this way, if you're fortunate, privileged enough to do so. So I had a lot of problems with it, and I referred a lot to qualitative research to try and give some human voice to this. And one of the consistent things you see in qualitative research when it examines these social demographic issues is that people in low socioeconomic areas know fucking fruits and vegetables are good for them. Yeah. So when it comes back to that, it's this assumption that people are fucking stupid if they're socially disadvantaged. It's such classist nonsense, and we need to move away from that rhetoric. Like, people know fruits and vegetables. Line 10 people up against a wall now, certainly 8 are going to know that vegetables and fruit are good for them.
They're not going to say they're bad for you unless they're doing some sort of carnivore diet at the moment.
The barriers as to what, and if ever anything was privileged, it's the carnivore diet, right? But the barriers as to why and how people cannot affect this stuff, again, have nothing to do with nutrition. So one of the variables with fruit and vegetables is that they're perishable. They're really quickly perishable. So even if you have a degree of food preparation skills in a low income household, the priority is to not have food that essentially could be money wasted if you buy this stuff and then it goes off and spoils. So again, the free markets of the scenario cater to this. You can see some really interesting papers that look at the composition and contents of what's in a supermarket or a store, again, relative to different levels of social deprivation in an area. And so you will go into supermarkets or food retail outlets in socially deprived areas, and it's just literally all canned, packaged, and shelf life extendable goods options. So that's another factor that then plays into the nutritional quality and otherwise of the diet. But actually, one of the real constant barriers that seems to come through the literature in this area is time.
100%.
Lack of time. And you might have people that are working more than one job.
Exactly. So for us who are giving out this kind of information, as you said earlier, and I'm glad that you did, we typically, especially doctors, come from a higher socioeconomic class to begin with. That's not something that is necessarily a fault. It's just a fact.
You can't pick your parents. We're not assigning blame here to people that were born into more advantaged circumstances, as much as we're not assigning blame to someone.
But so within that, I don't. The most I've never worked 2 jobs at the same time. Like I worked, which again, ironically, was probably more than a lot of the people I went to medical school with did. But I worked to earn money whilst I was at medical school. I worked in an electronics store to help pay for rent whilst I was at medical school. A lot of my peers didn't have to do that.
Right.
So I have actually worked in a quote unquote normal job, but I have no idea what it's like to work 3 jobs. No. I don't have any kids, so I have no idea what it's like to work
multiple
to
jobs
bring food home, to bring money home, to pay rent, to pay for if shit hits the fan, everything falls through, I can move back in with my mum. Like it's like that in itself is a privilege.
Security.
Yeah, exactly. Yeah. So so us having these conversations, we have no real personal insight or understanding of what it's really like not to have the time.
Exactly.
We think we don't have time. We love to complain.
Yeah,
the middle class love to complain that we don't have time, but we have time to watch a whole series of Game of Thrones on do you see what I mean?
Right,
So we do have this time, and that's I think a lot of where some of this information and some of this rhetoric around you just need to prioritize your health comes from within our own class in a sense that it's like if you have the ability to watch a whole season on Netflix and you have the ability to spend some time preparing food for lunch the next day, that's true, but we're talking to the people who have the ability to watch a series on Netflix,
and
they're not the people who are at the worst health. They're not the people who are eating the least fruit and veg in the first place.
And I think we said this in the last attempt at this, but when you see, certainly in kind of wider conversations online, and when you see a lot of the really strongly held opinions about personal responsibility, they tend to come from the fitness industry. People whose whole life is exercising, meal prepping, working in a gym, seem to think that, well, I can do this, everyone else can too. And it's a really difficult narrative to try and disentangle. Because
it's much more comfortable to shift responsibility.
Right.
It's much more comfortable for it to be someone else's responsibility to do something about it.
When you get into these conversations, actually, what comes back is that people will say that by focusing on these issues we're focusing on, us liberal, what do I remember the line some poet used on one post was limp dick enablers.
We're gonna get told off now.
Right. But like that's the perspective of some. So point being that the idea of focusing on these social determinants of health gets labeled as liberal, weak, enabling.
Yeah, no, I know what you mean.
And actually, that is all of this is accused of shifting responsibility. By focusing on the environment, by focusing on socio-economic and environmental determinants, you're shifting the responsibility away from the person, and it's like,
which is incredibly ironic.
Incredibly ironic, but also tragic and impossible to unpick. And again, you're uniformly talking about people expressing these opinions from a place of privilege.
Yeah.
And again, to reiterate for listeners, like as Josh was saying, like neither of us have any idea what this is like. We're speaking, we're lifting information from research, from papers, and we're articulating
and conversations with people.
Conversations.
I have heard, but I don't know what it's like not to own a fridge.
Right.
I don't know what it's like not to own an oven. I don't know what it's like to have to prioritize food over heating.
Right.
I don't, and I'm not,
or vice versa.
Yeah, and I'm not afraid of acknowledging that.
Yeah.
But at the same time, I know that if I ignore that stuff just because I don't personally know what it's like,
well, then we're not having the conversation.
No, that's just incredibly disrespectful of me to do that and to pretend that inequality doesn't exist.
Yeah.
And that those difficulties aren't, just because those difficulties aren't mine, it means that they don't exist. And that's just not right.
Yeah, absolutely. And it's a big barrier to a lot of these kind of wider social conversations now, is that I find bizarrely, although people talk about these issues with we must, give a voice to X, Y, Z. Conversely, there's this very anti-democratic element to these conversations where it's also, but if this isn't firsthand, you can't speak to it.
No, we all need to be speaking
And we,
about
we,
it.
we actually,
do.
what this is about is because this is so unspoken about, and because these issues that we're talking about are barely in the conversation, while everyone is screaming at each other about whether sugar is a toxin or fat does this, that, and the other to every aspect of it. It's just nonsense. So we can't come back to having nutrition conversations unless we have conversations about how to solve these issues first. And interestingly, here's a hard truth, I think, for people. If all of this were to absolve in a week, and we were going and we woke up in a week to a new society, a fair society, a society with fair, fairly equilibrium in terms of like a closing of this wealth and health disparity, the dietary advice wouldn't really change that much.
Yeah.
So the advice isn't the issue. Everyone's focusing on the advice. It's like, forget about the advice for now. We have a huge society-wide issue that needs to be addressed. And if we're not having conversations at that level, then in many respects, it's just like, it's not that we shouldn't have these conversations at all, but it's like, can we stop focusing on the stuff that doesn't really matter in the context of the big picture? And the big picture is these wider issues.
I think one thing I think actually I think we can probably bring that to a close roughly. Actually, I think there isn't necessarily. I think unless we're going to start speculating on how to fix these, which we don't have the ability to.
No, but I think there is one. I think there is one important thing to bring in at the end, and
I mean, I had one little anecdote as well, which I thought was quite fun. But yeah,
this
go on.
isn't even an anecdote.
Oh,
this
okay. Should I do anecdote first, and then you do
anecdote last? Because I'm just going to continue being depressing. When we really step back and look at this, and I've talked a bit about market forces and these kind of issues.
Yeah.
I'm fairly apolitical in my own perspective. I take part, as in I vote, because I believe it's important in a democracy. But I ultimately think that politicians ultimately, and this is just isn't in the UK, it's in Ireland, like, because of open market capitalist societies, most bright kids go into, a profession they can make money in, which generally leaves us with the rich and thick to actually run the country. So I don't have a lot of, so what I'm about to express is not necessarily a reflection of my political opinion. It's a reflection of coming back out from a lot of this research with no other alternative in terms of a conclusion. The dominant driving force, we can see this by comparing societies that embrace this doctrine versus ones that don't, appears to be neoliberal economic doctrine, the conservative libertarian approach to completely deregulate society, deregulate everything, let the free market decide. And the countries with that economic doctrine as their core political ideology are the US, the UK, and Australia. Ireland follows closely by, but we don't have the population to really compare to. But trends-wise, these are the countries leading the world in chronic lifestyle disease statistics. You compare that to countries with a more social democratic model like the Scandinavian countries, they don't have that wealth disparity, they don't have that health disparity, they don't have those extreme issues in chronic lifestyle disease. So I'm not saying this as like a left wing, like, oh my God, bring back, communism. I'm saying this as a conclusion that is very difficult to ignore from the evidence that exists for the forces driving these issues. And we can see that playing out now when we look at what's known as the nutrition transition in Asia, where transnational food and beverage companies penetrate emerging markets, initially using sugar-sweetened beverages as a means to get into the market, typically using mergers and acquisitions to buy up local companies, modify the foods that they're going to sell to kind of local cultural factors, and ultimately start to spread this relatively homogenous Western diet pattern in emerging economies. And Asia is the best case study for that. And we can link a particular paper that will give people a nice overview of these issues. So This is a political issue. It's a reflection of a political ideology and economic doctrine that has been embraced in certain countries in the West. And unless we're acknowledging that, we're again having conversations potentially in the wrong place. So we need to, food, I guess, as part of this needs to become a political issue. And that's where I see the conclusions. And it's ultimately where I see the fight that needs to be fought is at the level of policy.
Yeah. Well, I mean...
Which means we're fucked, because that's not changing.
Without a lot of noise, I guess.
Sorry.
Yeah, all right, grumpy.
Give us your anecdote. Make everyone fucking happy again.
I don't know if it does necessarily make everyone happy, my anecdote, but it is just... no, leave the jelly babies alone. They're just going to make lots of noise. I think the reason I've got this anecdote that I'd like to... Is it an anecdote? I don't know. This story / thought process to share is just because this is the thing that I heard first that made the most sense to me, that made me start questioning a lot of this stuff. And it wasn't necessarily about nutrition, but it was a real example of how socioeconomics can, especially socioeconomics of a perspective that we don't have any real experience in, can massively change the health advice that we think is so straightforward and so obvious. And that's...
I'm not sure I understand.
Neither will our listeners.
That is so straightforward. And that's in the example of something that's called, I was going to say, that's in is it a book?
No, is this the Ollie Williams smoking thing?
Yeah, but it's not his.
Oh.
And that's in, I think it's a book called Life's a Drag. It's a book, or it's a case study, or it's a paper of some kind. It's on Amazon. You can have a look at it. Essentially, where they had a look at single mothers in areas of social deprivation on council estates, and they looked at the kind of health status of single mothers who smoked versus the health status of single mothers who didn't on this particular council estate, and everything that I know from medical school, from medicine, from being a doctor, from even not being a doctor, everything that we know says that smoking is bad for your health, right? That there isn't, I couldn't foresee a situation.
There's no nuance in that.
No,
it's just smoking is bad for you.
I couldn't foresee a situation where smoking wouldn't be. And yet this case study looked at and compared those who did and those who didn't, and they found that the mothers that smoked actually had higher health markers than those who didn't. And
have better health markers.
Yeah. Did I say, what did I say? Higher. Yeah, higher. They had better health markers because for them, in the life that they led, it massively reduced their stress levels.
Fuck.
And there are so many things that can impact health that actually the things that we think are so straightforward for certain populations can be actually the complete opposite. And so for them, that was perhaps the only time they had in their day that was outside. It was the only time they had for their day that was quiet, that was away from their kids, that was a time to actually breathe and relax, which may have brought down their blood pressure during that time. There were all sorts of reasons why, and it was a time when they could talk to other people in a context that wasn't work, so it was social connection. And so all of those factors actually meant that they had better health markers than those that didn't.
Wow.
And so you're kind of going, as a doctor, what am I meant to say to that?
Right.
Am I meant if I say, the NHS has a stop smoking service that I can refer you to, because make every contact.
But then you'll be more stressed, have less social connection.
Yeah. And that's, but that's my job, right? Make every contact count. I should be mentioning stop smoking at every single consultation. That's my job. And so when I heard that, I was like, okay. It's like this, I'd never actually seen it in that way before.
Right.
In terms of, and I know it's not directly nutrition related, but it was in terms of this advice that we think is so simple. Eat more fruit and veg. eat less animal products if you can, don't smoke, exercise more. It means nothing if we don't understand the place that someone is at
Right.
within the social standing they have in society.
Right.
It means absolutely nothing, and
Right.
and it is almost insulting for us to be giving out this advice when we have the ability to see someone one-to-one,
Yeah.
and we don't take into consideration
Right.
anything else that may be there.
Yeah.
It's really created a new thought process.
I was
for
thinking
me.
a lot about that recently, because I've been seeing a lot of when people interpret studies, I've been seeing just this real fundamental misunderstanding of relative risk, and people just think it's just a percentage you express. So, well, if the relative risk for cancer because of consuming something, or heart disease because of consuming, do you remember that one rasher a day thing,
Yeah,
24%?
yeah.
Well, then people are like,
Of
well, you
baking,
look at the baseline risk for heart disease, and then, well, actually all it means is that 1 in 4, was 1 in 5, say, would get heart, and the increase was to 3 in 5 or something like that. So, but what I was trying to articulate was, yes, that's true. The absolute increase in risk can often seem less than the percentage can make it seem higher. But that's not what relative risk is. Relative to the population studied,
to the person, to
so
the
it's
population,
relative to that population. So relative risk is saying that the risk given this population, given their traits and characteristics, this is the relative risk increase, right? And so it's appreciating that, that relativity element to, if we're looking at any disease outcome, if it's set against the backdrop of really high levels of stress, lack of time, money worries, professional stress in the context of maybe having to work more than one job, and all of these variables, the relative risk of smoking cigarettes may be somewhat less in that context, because you have all of these other lifestyle variables that are probably going to result in a chronic lifestyle disease anyway. And I'm not saying that lightly. I'm saying that in the tragedy of the wider circumstance.
Yeah. Now, again, that doesn't mean that the advice to not smoke is
Of course
bad
not.
advice.
Of course not. No.
All it is a prompt or a bit of a nudge to take some of this stuff in consideration, that we should be at least aware of it. It doesn't change the truth of the matter for a lot of these things. It doesn't change just because some people can't access fruit and veg. It doesn't change the fact that it's good for you. But it is important to know if they have the ability to access before we insult them by just telling them, that's the only advice we give them.
Oh, they obviously don't know that fruits and vegetables are good. We'll just we'll just educate.
Yeah.
No.
Yeah. It's insulting.
It is insulting.
But take 2 was much better than take 1.
Yeah, take 1 really went down the neoliberal rabbit hole.
that was good though. I'm glad that we stopped that and re-recorded that. Much protest from you. You looked at me like, well, what? No, it's fine. Stop. It's just because I'm glad we re-recorded that. I like that as an ending to season 1.
I do.
Of our Cut Through Nutrition
without
podcast.
Having to feel like we need to solve these issues. Not we as in us sitting here, we as in you as listener, no doubt falling into the same relative socio-demographic bracket that we do, and I don't think that's a stretch as an inference, but it's about perhaps collectively now all being more mindful of these issues, having the conversation in your space as well. So for a lot of the healthcare professionals listening, not just factoring them in, but actually having this conversation with others that may not be considering it. And the more we can try and start to bring about a critical mass acknowledging these issues, the more we can make it, a ballot box agenda, and, start to hopefully press, agitate, lobby, and otherwise for the kind of political solutions that will ultimately make a difference in society. But
So
this is a
season
long-term
2 is going to
game.
be how to lobby your politician for change. No, it's not.
it's not.
But I'm glad that we ended season 1 in that way because we want to move on to talking about, as we said, certain conditions and almost kind of have a literature review in podcast form of what do we know at the moment about this stuff? Where is the nuance here? What is the evidence for and against these kind of things? And the things that we've talked about during this season, in our opinion, are all really important things to be acknowledging of.
They're the context.
To be able to have that's the background, to be able to then have these conversations and put them into practice in a way that is appropriate.
Yeah, without having to revisit these issues every time.
Yeah.
Because, what can happen, certainly in nutrition now, is, we might start talking about diabetes, for example, and nutritional determinants and all that stuff. And then someone comes out to beat you with the socioeconomic, kind of tag. And it's again, we're saying that we have considered these and will continue to consider those issues. But
those are a given with all of the conversations we have in the future.
They're the continuous variable here.
Yeah. And I'm sure we will probably mention them in the future.
Yeah, absolutely.
With certain things that are specifically important with it. Yeah. But just because we don't necessarily mention it with everything, it doesn't mean that we
are not considering it.
Yeah, that we're not acknowledging it as a factor in all of these conversations. Just like nutritional identity is a factor in all of these conversations. Just like the different rhetoric that people use is a factor in all of these different conversations. Just like the fact that people don't necessarily know how to read nutritional science literature is a factor in all of these conversations. And we'll bring individual ones up when it comes to it, when it's appropriate. But that's our point. And I've enjoyed season one. I hope we don't leave it too long for season 2, but we'll have some little probably a few Q&As in the meantime whilst we get season 2 up and running.
So if you have been enjoying this, and this is the first time I've said this, but do leave, if you can, a written review, because it does seem that the only people that go out of their way to write reviews are people that want to rant in a negative sense.
Well, look, negative feedback
that's fine,
can be helpful.
But there just seems to be a disconnect between the written negativity and the actual star rating. And I'm just like, well, if people are liking this, it's just at least say...
Leave Alan a hug in written form, please.
I don't need a hug. I'm devoid of emotion.
No, you're not. You're not that communist.
No. Thank you for listening.
So thank you for joining us. We will be back in 6 years' time with season 2. No, it'll be a bit quicker than that.
We're waiting for the Game of Thrones creep to write his last book, and then we'll come out with season 2.
We'll be quicker. We will. But thank you for joining us, and we will see you next time. Still without a theme tune, probably.
No theme tune.